Hey, so what I want to do with this is do a little exam one test review. This is for my students, but I'm posting this for anybody that it will help. Acid base or gas exchange are the two concepts that we're looking at. So let's get started. COPD, things to remember. One, PFTs are pulmonary function tests, and this is how we diagnose COPD. You need to understand that. Go back into your book, look up PFTs. That is something, and that is how we diagnose COPD. And if you know that, then when the doctor orders that, you understand what's going on. How many liters of oxygen should a COPD patient be prescribed? Once again, as the nurse, if you're putting on oxygen, 2 to 3 liters max is what we want on a COPD patient. If we increase the oxygen, we're going to decrease their respirations. We can make them stop breathing if we are not careful. We are okay with a COPD patient having an oxygen saturation, an SaO2, of 88 to 92%. So you want to make sure you put that in your mind and remember that, because when you're caring for that patient and you look up and see 88, you're going to go, oh my gosh, it's below 94, or we're down under 90. Just remember that might be where these patients live. That's their norm. Remember that they should get vaccinated for pneumococcal pneumavax and influenza flu. Every 5 years is the pneumonia vaccine, and every year is the flu. We'll also probably start to see COVID being a vaccine that's given to COPD patients and other patients with asthma and other respiratory issues, because we want to hopefully help or prevent them from getting, or if they do get, that they'll have lessened symptoms. Just remember that. What is the number one cause of COPD, and what do we do as nurses? Number one cause of COPD is smoking, guys. Smoking is the number one cause. What do? Have them quit. We need them to quit. It is so important if they will quit. The thing to help them quit is it's an addiction, nicotine. Nicotine patches can be ordered. As the nurse, if you know your patient is a smoker, no matter what that enters into a hospital or a clinic, you can ask the physician to order nicotine patches to help them. There's medications out there also, you do not need to know those right now, that help a patient quit smoking. But it is one of the things we need to do. We need to get the medicines, the patches, whatever we need to do to help the patient quit. The other thing I want to say about this, and it's important to understand, is if the family member smokes, that can be a trigger for the patient or client to smoke again, because they smell it. It's an addiction. They smell it. They want it. So it needs to be a family friend event. If you're going to quit, we all need to quit. Or if you're going to smoke, don't smoke around your patient or your loved one. And the other thing is remember that if you smoke, I'm not a smoker, but if you're a smoker, just know if you smoke and you're around a non-smoker or someone that's not smoking at the time, they're going to smell that smoke even on your clothes, your breath, all of that. We need to make that very clear with their loved ones. If they're not going to quit with them, then they need to make sure they're not going to trigger them to start smoking again. Understand what is happening with the patient with emphysema and what are the signs and symptoms of emphysema. I'm not going to go through those. I go through those in detail in the lecture. They're in detail in your book. You need to understand the difference in the signs and symptoms of what's presenting as an emphysema patient and what's presenting as a chronic bronchitis. The emphysema patient, is the pink puffer. And what are the signs and symptoms? What do we see? Okay. How and why do we use purslip breathing? Well, purslip breathing is a technique that keeps the airway open longer. It's going to prolong exhalation, allowing increased time for oxygen and carbon dioxide exchange. So it is so important that we teach patients how to do purslip breathing. It's where you close the mouth, breathe in through the nose, both nares, for 2 seconds, blow out through your mouth with a kiss-like motion with your lips pursed for 4 seconds. By doing this, what we're allowing is for that gas exchange to take place if possible, because it's not taking place, due to the damage of the COPD. So we want to make sure that we teach them this so that we keep the airway open longer, it prolongs exhalation, and allows increased time for oxygen and carbon dioxide exchange to take place. That's why we do it, and that's how we do it. What is cor pulmonale? And the signs and symptoms. Just remember that's right-sided heart failure. That is where, and what happens with that. I gave a whole big lengthy explanation about that in the lecture. It's in the book, but you need to understand what it is and what we're seeing with that. Remember your dietary needs for the COPD patient. If they need oxygen, they can wear it while they eat. If they feel they should rest an hour before. Conserving energy and oxygen, eat 6 small meals in a day. They can drink fluids to thin secretions. We need to just make sure they understand that. Now, if they're in a heart failure, we're going to have to watch our fluids. So they need to do what the doctor orders, but we also need to understand all those little things that a COPD patient needs to remember when eating. And you need to make them understand. If they eat 3 meals a day, normally, they get up and have this huge breakfast, and then, they might snickety snack, and then have a big lunch, and then another little snack, and then have a dinner. And that's how they've eaten all their lives. And now here we are. You're going to need to, 6 to 8, depending, small meals. They need it high in protein, low in carbs, right? We want high protein meals for energy. We need it. It is broken down in the lecture, so just go back and review that. Okay, let's talk about asthma. What do you do if a patient is having a severe asthmatic attack as the nurse? There should be an E there. I see that. It's not a severe. But anyway, one of the things we want to do immediately is we want to give a bronchodilator. We want to open the bronchioles so that they can breathe. It's not an oxygen issue at this point. It's a mechanical situation going on. We need to do something to open the airway, right? That's what we want to do. With this patient having a severe asthmatic attack, we want to sit these patients up. We want to initiate an IV access so that we can give medications if necessary. Always complete a respiratory assessment. It's a focused assessment. We want to know. You want to listen to what's going on. You want to watch what's going on. How are they breathing? What does it sound like? What do we see? And the other is you do want to monitor their oxygen saturations. We've got to make sure that they're maintaining an oxygen saturation. For children, 90 or greater needs to be for anybody, but definitely for children. We don't ever want them to get lower than 90% because that means they're actually starting to really decline, and that's not good. Children will cope, and they will hold on, and their bodies will work to try to correct what's going on, and then they will eventually start to break down. And when they start to get down lower saturations, oxygen saturations, when we get below 90, they're in trouble. They're in big trouble. They're in more trouble than even an adult at this point, just so you know. Understanding bronchodilators and why do we give them? You need to go back and look that up. We know that they're going to open the bronchioles. Why do we give them? You need to go back in the chapter and look. Albuterol is a bronchodilator. That is the one I want you to know. You see it on the list of medications. There's some others. But those drugs right there are the medications, albuterol, Qvar, corticosteroids, or Flovin inhaler. Those are the ones I really want you to understand. Why and when do we obtain a peak flow reading? There's a video for you to watch on how to do a peak flow, use a peak flow meter, and why do we do it? If you have an asthmatic patient that comes in and they're feeling some tightness but in their chest, but nothing else. There's no other signs of anything going on. They're not in distress or anything. Go ahead and do a peak flow meter. That will give you the information needed if they are going into an asthmatic attack. If that's the case, then they can take their inhaler, or you can provide, the doctor can prescribe an inhaler, and you can give them the things that are necessary to hopefully prevent them from getting worse and correct the situation. So the peak flow reading, or using the peak flow meter, chest tightness is the sign of asthma. If they have that, nothing else, we want to see, like I said just previously. And then also, you can have the patient lie down, but most of the time patients feel better sitting up. It just depends on the patient itself. Collect all the data, listen to their lungs, start to look. And if this is the case, we're having this, we want to give a long-acting beta-2 agonist. We want to go ahead and give that inhaler so that they can, it will help them at this point. The other thing is the medications I want you to know is albuterol. I mentioned it a little bit. Go ahead and look that up. You need to understand it. And what if I give an albuterol treatment to a patient, it can cause a lot of side effects. And that's something that we need to explain to the patient. They're going to get jittery. Those things are going to happen. Go ahead and look those up. You need to know those. QVAR is another one. Understand which one goes first, which one, how we give it. There's a whole thing in your book on that. So go ahead and find that information. Corticosteroids. This is something that we do give. It's Flovin inhaler as a corticosteroid. We usually give that as an anti-inflammatory. We want it to have that effect, because we have inflammation, and with inflammation we have all these issues, tightening of all the in our lungs, so that we cannot breathe. This is during asthma. So we can give corticosteroids, Flovin inhalers. Understand giving those. There's different inhalers we give. We want them to rinse their mouth out afterwards. Do not swallow. I want you to go ahead and review these that I've given you and understand those things. What are side effects? When do we give them? Which one would we give first? Why? They're in there. They're in your reading. They're in some of the video stuff. And also, which ones do we need to rinse our mouths out? Which ones are we okay to not? Why do we want to say to a patient, you know, if you'd like to have something, piece of gum, they get a bad taste in the mouth, things like that. We need to understand that, because as nurses, we're providing what we need. I also reposted a different how to use an inhaler with a spacer. It's something to watch. It's not very long. Look at the videos. They're very helpful if you haven't watched them yet. There's some in the outline, and there's some that are on the lecture. So that's up, that's up to you. Identify your patient. This doesn't make that much sense, but I want to say, be able to identify a patient. If you have a patient and they say, this is how they present, this is what you're seeing, you need to know the signs and symptoms of status asthmaticus. They're going to be in severe respiratory acidosis. They're going to have all of these. And then what do we want to do with those patients? We're going to give a beta-2. We are. If they're experiencing status asthmaticus, they're going to have wheezing, they're going to be labored breathing, they're going to have that nasal flaring. Remember in the lecture, if they are air hungry, they're going to have the nasal flaring. We see it. Administer 3 treatments of a beta-2 agonist, 20 to 30 minutes apart continuously. This is going to help. Also, a Singulair can be given at this time. It's an oral medication that helps with inflammation. But if they're in severe respiratory distress, they're not going to be able to take oral meds, and you need to think about that. If you take something, what do you have to do? Close your mouth and swallow something to get it down, right? Water or whatever. If they're in severe distress and they're not going to be able to. But if they can, and you're assessing your patient, you get to a point, just know that Singulair is an oral medication that helps with inflammation during this. Teaching the family to prepare the home for a child with asthma. That is in your book. I want you to go back through that. They don't need carpet. What does carpet do? You know, it can cause pets. Do they need pets? The dander, those things, those could be triggers. Laundry soaps we need to look at, soaps that they use, things like that. There can be a lot of problems based on that. There is different things we can use for dust mites on the curtains. That's important. You know, they need to spray every 3 months to make sure that their dust mites are down. You have to not only prepare the house, but keep it safe for these asthmatics, especially small children that have severe asthma. You want to make sure, hopefully they'll outgrow it in time and get better, but there are adults with asthma also. Go back and review asthma, guys. It's something to really understand what you do as the nurse. I want you to critically think, what am I going to do as the nurse and how am I identifying this? If I've told you in these I'd be able to identify through signs and symptoms, that means you need to go down and look status asthmaticus up and write down signs and symptoms, what I'm going to see. Labored breathing, wheezing, nasal flaring, and there's others. Get those and get them on a card so that you understand that's what you're seeing. So let's talk about RSV. How do we spread it? Well, if you go back to your book, and I'm going to pull my book over because it pretty much lays it out, right? It is spread by direct contact with respiratory secretion, usually by contaminated hands to the mucous membranes, which is your eyes, mouth, and nose. We all know that children are little germy people, and they love to touch and share toys and do all that, so they spread it like wildfire. It survives for more than 6 hours on countertops, tissues, and soap bars. It is not spread via airborne, and we need to understand that. It is not an airborne, so they're not on airborne precautions. They're on contact isolation, because whatever we touch, okay, that's what we need to remember. That's how we spread it. So what is the one thing we really, number one thing, wash your hands with soap and water. If we didn't learn that with COVID, we need to know that. RSV went rampant after we came off isolation. A lot of adults are getting it too. Wash your hands, understand it lives for the 6 hours. We need to make sure that everything is, you know, we want to make sure we protect ourselves, protect the patient, and we don't want it spread. The child needs to stay home, isolated, all that good stuff. Always remember, guys, that a child's oxygen saturation should never be below 90. So if I'm looking at a blood gas, or I'm looking at a patient, a child, a pediatric patient, and I see a SaO2 on the monitor less than 90, the first thing I need to do is start oxygen. I need to oxygenate this patient, and then I need to move quickly in whatever else I can do. I know that oxygen is a drug, considered a drug, and we do have to have a doctor's order for doing it. Normally hospitals and other clinics have protocols, especially in the hospital, and we'll have a protocol that, you know, if you have this going on with your child, this, you know, if you have a child, we want to keep all children's sats above 90%. If not, please start oxygen, you know, at 3 liters or greater to maintain an oxygen saturation of 90% or greater. Call the doctor immediately and get oxygen on this patient, but you want to get the oxygen on. We need to get them up. Children that have sats that drop, if they're at 100%, right, that's a perfect oxygen saturation. If it starts to drop down to 98, 97, we're good. 95, they're sick. We know it's going to be there. 94. When they get to 90, we're getting into trouble. Let me see if I can draw something on this slide. So there's a thing called a bell curve, right? And the way to think about this with the oxygen saturation, just very basic, is that at the top of this is 100%. If I can draw with the little thing, numbers, right? If that's 100% right there, if this is 90%, Anybody in between 100 and 90, they're pretty good, right? We're okay with that. And with a child, we are. But I want you to look at this. I think of it like on a skateboard. We're on a big hill, right? At the top of the hill, if you're sitting top, you're flat on your skateboard. You're not going anywhere, are you? You're not going down. You're just kind of sitting there. We're 100%. At 99, we're getting a little bit of movement. 98, a little bit more movement. 97, 96, 95. We're about right here at 95, right? Look at the curve. If I'm on a hill, what's going to happen? I'm going to start to pick up momentum, right? I'm going to start to go down that hill faster and faster. If that's the case, and this is 60%, which is death, right? Anything we get down in 70s, we're pretty much coding, arresting. There's bad things. 80s, low 80s, we're in bad shape. 60, we're dead. That's considered death. So if that's the case, if I have a oxygen saturation of 90% on a child, I'm behind the 8 ball on this, right? Because after that, they're going to start to go downhill quickly. Same with an adult. Now, COPD is a little bit different because we're looking at a gas exchange issue. But for an RSV and a small infant or a child, we need that SAT 90 or greater. We don't want anything less than that, or we're going to start to plummet and go down quickly. So that's just kind of a quick little thought so that you can visualize why it's so important to keep an oxygen saturation above 90. How do we diagnose RSV, guys? We do RSV antigen washing. So if you have a patient that comes in, remember your signs and symptoms of RSV. You know, they're cold-like. Go back in your book, look them up. We have the cold-like symptoms, all of that. They come in like this, and we question or think maybe RSV, or we want to rule it out. We have to do a washing. And it's a nasal washing, and we'll get that and send it off. It needs to be put on ice. We need to make sure that it's processed correctly through the lab. But that's a little bit on RSV. Make sure you review that, looking at your patients, because we want to do the right thing. There is the prevention piece is hand washing. Let's understand that it's spread by, contact. We need to stop all of that. There is a actual prevention of a monoclonal antibody that can be given. I'm actually going to probably butcher the pronunciation of this, but I think it's Synagis or Synagis. This is given monthly IM, but it is only, and I want to make sure people understand it, it is to help prevent it, but it's also given as a preventative therapy. The guidelines that state the candidates for preventative therapy includes infants with bronchopulmonary dysplasia, severe immunodeficiencies, or significant congenital heart disease, or need continuous mechanical respiratory support. Those are the patients that get this. Not everybody. We don't go into the daycare and start giving it because they get it from the start of the season of RSV, every month an injection until it's over, in hopes to prevent them from getting it, because it would end up harming them or even possibly killing them. The next thing that you're going to see on the test are ABGs. You did an ABG interpretation and you guys did great. The majority of you did great. If you made any mistakes, go back, kind of look at it. You will do some interpretation on the test. So you might get, these are your ABGs. What do you think your patient's in? Respiratory acidosis, alkalosis, metabolic acidosis, metabolic alkalosis. And you'll need to identify that. And it's very straightforward. The other thing, remember your lab values though. To interpret those, you've got to remember that your pH normal for blood, the blood pH is 7.35 to 7.45. Your CO2, your PaCO2, carbon dioxide, should be 35 to 45. And your bicarb, your HCO3, PaHCO3, is normally 22 to 26. Those are the numbers you need to know. As soon as you get your things, as you're trying to remember, write those down so you can interpret your ABG, figure out where your patient is coming from. One of the things I do want to put on here is to understand that signs and symptoms of respiratory acidosis, metabolic acidosis, I just put ... I didn't want to type them all out. Respiratory alkalosis, metabolic alkalosis. Go back and on those slides, you're going to see For example, symptoms of metabolic acidosis are weakness, lethargy, headache, confusion. Respiratory acidosis, we get weak, we have difficulty breathing, dyspnea, restlessness. They're really restless, guys. They get that impending doom if you haven't heard of that. Confusion, again, sleepiness, changes in mental alertness. They get sleepy. So go back, look at your slides, and look at signs and symptoms of respiratory acidosis, metabolic acidosis. They're different, and you need to be able to differentiate between them. So if I come in and look at vital signs and I see my patient present this way, my thought should be, and I know that they're already having respiratory issues, my thought should be, are they in respiratory acidosis? Are they in a metabolic acidotic state, alkalotic state, whatever? And based on the signs and symptoms that I'm seeing, should be able to trigger me to know. But the best way to know what your patient is in, the most definitive way of diagnosing where they are, looking at that, is ABGs, arterial blood gases. They tell us the truth of our oxygenation and where we are in an acid-base state. Also, do not forget, if we have metabolic acidosis, it's diarrhea. We're having excessive diarrhea. If I'm vomiting or I'm connected to suctioning, I should think that I am at risk for metabolic alkalosis. I'm throwing up, right? If an NG tube's down and it's sucking everything out of my stomach contents, it's the same as vomiting. So that should trigger you that they might get into a metabolic alkalotic state. And vice versa with diarrhea, we see the acidotic state. Respiratory acidosis, we're not able to blow off the CO2. CO2 is acid, and if we're retaining it, we become acidotic. How do we retain it? Well, if I'm a COPD or I'm retaining, if I have had surgery and been put under anesthesia, it suppresses my respirations. I could be in a respiratory acidotic state. Anything that suppresses respirations, I can't breathe out or off my CO2, can cause respiratory acidosis. Respiratory alkalosis is where I'm anxious, I hyperventilate, I'm blowing off. I'm either huffing it all off, I'm blowing off the CO2, I'm alkalotic, or if I have a patient that's intubated, I can actually bag too quickly and blow off all their CO2. Or if I have just the mask and I'm actually trying to bag with a mask, I can go too fast and it'll blow off their CO2. So what do we need to do? We need to slow down their respirations, and we can give them a brown paper bag to breathe back in their CO2. We still do that, guys. Good old brown paper bag. Some things are good forever, is my personal. So ABCs, I added this slide because when you're learning about gas exchange or respiratory issues, you need to think airway, 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 airway. ABCs, it's what we do. Airway, breathing, circulation, priorities. If I'm not breathing or I can't breathe, then nothing else really matters at that point. You know what I'm saying? Then we need to make sure we have an open airway. That's what that means. Air is able to get in and get out. Breathing, that I am actually physically taking a breath, and circulation, I have a pulse. Those are the things that we need to know. Saying that, I'm going to just talk about a few things. If I have a patient that has any acid-base imbalance, you're aware there's an acid-base imbalance, metabolic or respiratory, I want to assess my airway. That is a priority. I want to do a respiratory assessment and look at my rate, my rhythm. I mean, we know, there's different rhythms and rates when we are in different states. They're going to affect the oxygenation of our body, the gas exchange. So we need to assess that always. Any acid-base imbalance, we're going to do, look at the rate, rhythm and depth of respirations. We want to do that respiratory assessment. Take a listen to. If I have a patient that has a low SaO2, or I get an ABG and I have a low PaO2, which is, I know that less than 80% on my blood gas ABG is hypoxic or hypoxemia. If that's the case, I need to be oxygenating. I'm not going to be able to perfuse and keep tissue alive, right? I need to oxygenate for this reason. It's why we breathe. If I have a child with a SAT, and I'm saying it again, less than 90%, then I need to put oxygen on that child. Okay. If I have a COPD, or I want to be very careful putting oxygen on, they can live in a lower oxygen state, oxygenated state. They can have a SAT of 88% to 92. That's normal for them. We're okay with that. We understand that. We understand what's going on. We've learned what's going on in the lungs, and that's why we're here. But anybody else that has a SAT that drops below 90, we need to be putting oxygen on them first thing, right? If I have a chronic bronchitis and or a flu or anything like that, any of the disease processes in the respiratory world that causes excessive mucus, where I'm really producing excessive mucus, I need to clear the airway. If it's occluding the airway, I need to clear it. So if I have a patient that has a tracheostomy and there's tons of secretions coming out of it, I need to clear it so that they have a clear airway so they can breathe, take the air in, breathe, and then hopefully have a pulse and circulation, ABCs. If I have a child who has excessive or copious amounts of secretions, one of the things I want to do is clear that airway. I'm going to suction them to make sure they have a clear airway. So if you have a patient that has been moving air, let's say an asthmatic patient that comes in, and you're able to hear air moving in and out, they're wheezing, but you can audibly hear it, everything, and then all of a sudden they go quiet. That is a red flag. You are in an emergent situation. They need oxygen. They need airway. You can't just put oxygen on an asthmatic patient because the airways are closed. We need to be giving those bronchodilators. We need to be giving all the medicines that we can to open the airway up, and then supplement with oxygen to get the oxygen saturation up when needed. Those are emergencies, so make sure that you understand if you have a patient. It goes back to the old saying of a crying baby is a healthy baby or a good baby. When you're in an ER, if you have a baby that's crying, we know that 1, they're alert, 2, they have an airway, and 3, the louder the cry, we know that they're moving air, right? Because when you cry, right, we know things are happening. This goes to this. If you can hear a patient moving air and they might be wheezing because of, say, asthma, then all of a sudden you don't hear it. What do you want to do? You want to intervene immediately. And that's the person that you need to see first. If they have decreased respirations or anything like that, or if all of a sudden you hear them and then you don't, they're in trouble. You need to move in quickly. One of the things I want to say about this too is prioritizing care. You could have a COPD that's got a SAT of 90% that has been having a little more secretions, that kind of stuff. You might have a patient, a child that's having an asthma attack, and but they've done their peak flow meter and they have been administered their bronchodilators and all of the inhalers that they need, and they're doing a little bit better. Their oxygen saturation is 92% and they're not in any distress. Then you come across a patient, let's say another asthmatic patient, and you have diminished breath sounds and you hear diminished wheezing, meaning I'm not audibly able to hear them. It's when I put that stethoscope and you hear that. It's a very dull. That means those airways are closing down. That is your priority patient. Please think about this. So don't get fixated. One of the things for critical thinking and becoming that nurse, a good nurse, is understanding I've got things going on and what is my priority. And that is these patients, just so you know. Now, this is a brief overview I want you to go through, but create your study guide. Look at the slides, look at your reading. Go ahead and understand that you need to know what your priorities, nursing priorities are, what you're seeing, why are you doing it, and understand that the concept is gas exchange or acid base. But if I have a patient that can't breathe, what do I need to do? Do they have a patent airway? Are they breathing, right? Are my ABCs? How do I do it? And that's where we look at an asthmatic patient. How can we prevent things? One of the things nurses do is we prevent or teach to prevent. That's what we need to do. If you've got a child, we need to prevent them from getting RSV if that's what's happening. If it's asthma, what do we do to prevent an asthmatic attack from happening? You know, dander and carpeting is a no-no. We don't want those things. Smoking is bad, right? If you're a COPD patient, do you want to put a bunch of oxygen on? No, you don't. Do you want to quit smoking? Yes, you do. Those things. I want you to start to think that way. You need to, but be able to identify. And I think I've kind of flagged those things here for you to focus you so that you can start to bring that all home. I think you're going to do great on your test. Take a big deep breath. Don't be overwhelmed. You've got this. You really do. I'm excited. Talk soon.